I just thought that I wish that I didn't have time, so I wouldn't make the presentation, but I have time. I will be talking about the adverse effects. During my residency, I dealt with neuroleptic malignant syndrome, and certain syndrome, and extrapyramidal syndromes. I was wondering why all these are evaluated within the same category. And these, when I learned about the biological mechanisms, I could differentiate why they're all in the same category. So dopamine synthesis through serotonin goes tryptophan, but there are similar enzymes using the same cofactors. However, serotonin and dopamine acts in adverse method. Direction. So, for example, when we give neuroleptic, the dopamine decreases and serotonin relatively increases. So, for that, it is as if there's an excess in serotonin. So, neuroleptic symptom may be similar to each. Extrapyramidal, what is it related with? For example, we want to move, and the prefrontal cortex says that it helps us to make our decision, and frontal system says that we can move, and cortical spinal tract is now in is action, and now I will walk, but I have to regulate this, and then the pathways go to the pyramidal syndrome, this basal ganglia system. And there what happens is that they can increase our movement, they can decrease our movement, and modulate. Well, if they do not increase, uh, I cannot move. If it decreases, that it means that it decreases the unwanted movements like tremor. Normally, I should not do like this, but if I cannot modulate, so it means that it moves in this way in an unwanted way. So it means that decrease the unwanted movements, and the ones I want would be decreased, and it is modulation. Dopamine modulates this, so it does not only ensure the moderation of the dopamine, it also regulates the hypothalamus. So for that related dopamine system, the findings in this, they have the similar symptoms. For example, neuroleptic malignant syndrome. So when we say that the all similar findings are here because they use a similar mechanism, the etiology is only different. And here it is not known in which frequencies that they may be in very mild or moderate or severe condition. There we cannot recognize the mild situation. We cannot identify the frequency or prevalence. And so we see that central dopamine hypoactivity. So it's said that hypodopaminic process. So we see that dopamine can be given as an antagonist, and we can stop the agent. For in Parkinson's, L-DOPA is given, and then when it's stopped, all phenomena is occurring, and it's a neuroleptic malignant syndrome disruption. So it talks about disruption of dopamine tracks. It means that antibodies, because it's very sensitive in terms of inflammatory. So serotogenic and neuroleptic malignant syndrome and EPS can emerge. So I have identified in my mind is that so farm, this is how I identified. So altered autonomic rigidity and mental dysfunction. So here it affects the hypothalamus because there may be fever, there may be catatonia, and there may be the EPS symptoms. So there are many manifestations. For example, what are autonomous dysfunctions? Rigidity, delirium, muscle rigidity. So what we have in laboratory is that so the serum iron is very low because iron is in use in dopamine synthesis. So for that reasons, if there is less the deficiency in iron, it is restless leg syndrome. So it means that dopamine is less. So for that reason, it increases the risk, but this is also what we can find. Neuroleptic, it is not defining of the neuroleptic Melin syndrome. And there are many criteria. So I give a lot of scores are given. So if there is rigidity, it's 17. If there is hyperthermia, it's 18. And if there is mental status alteration, it's 13. So if it is 74 from 100, then I would call it an Mellin's syndrome. So serotonergic syndrome, and there are many others. So for that, when I say that when I make the diagnosis, so then there's a kind of consensus, and they said that then it's if there's an elevated creatine phosphokinase, then I would add 4 points. In risk factors, for example, the deficiency in iron is related to the synthesis and the substance use and GABAergic withdrawal. So the GABAergic agent is withdrawn. It is in favor of glutamate, and it increases the excitation. So once again, what it is related with, for example, there might be a sudden use of a drug, and then the problem is that, let's say antipsychotic is given, and then we give another one, anticholinergic, thermal regulation is deteriorated. So for that reason, this is not a process that prevents us from NMS. It may also worsen it. And so what are differential diagnoses? Catatonia, what is lastly imaged. Catatonia is a big picture in it. NMS and serotonergic syndrome are within this picture, and etiology may be changed or different. For example, malignant or non-malignant catatonia, agitated delirium, serotonin syndrome. We are talking about different parts. And what is the differential diagnosis? Neuroleptic Melin syndrome. There's an antipsychotic agent is started, but in catatonia, there's not such an episode. So if we just go in with the clinical course, we can start within the 1 month. So 16% of them may take place on the first day. It starts within 1 month and is over within 1 month. So it may be over within 1 month. It may also start onset earlier and be over in early time. So if there is risk for increased mortality, so what happens in the children? Cerebral palsy children. In the case of spastic cerebral palsy, the basal ganglia are affected. With the agents we give, there are more adverse effects and agitation. If there is an failure in the kidneys, then there's more problem.
For example, let's assume that, God willing, child did not pass away. In this way, it can leave some cognitive sequels in the upcoming period. So its morbidity is high too. What's the treatment? The cessation of the drug, the intensive monitoring. Of course, we have to recognize it early. We have to stop or discontinue the drug. Dopamine agonists can begin, but of course, it's related to finding temporal and implementing amantadine. It's harder in Turkey. What we are doing, benzodiazepine. What's the dose of the benzodiazepine? We are to an extent afraid of benzodiazepine because of respiratory depression, but this will kill. If it's just a respiratory depression, we can just interfere, but it can be heightened until nystagmus point. How do we look at it? Neurologic. In order to increase gabardines, we are giving benzodiazepine. The people are giving benzodiazepine, and we are always controlling until nystagmus come out. Until nystagmus come, we can increase dose. But in our normal practice, for example, Rivotin, I'm starting with quarter or 2 times quarter, and then they can easily go to 2 times 1, 2 times 1.5. This is called high dose for our children. Until nystagmus sign is seen. If nystagmus is seen, it means that cerebellum is affected, brain stem will be affected too, we have to stop. But sometimes we are afraid of the results, that's why we are intubating before increasing dose. We have to save it from here. Dantrolene doses have been specified, but it's not very easily accessible in practice. Amantadine is known as a kind of flu drug. It's a dopaminergic agent for Parkinson, but it's called to be administered, but I have never witnessed another doctor who are giving this drug. They are mostly giving other Parkinson diseases, mostly in intensive care, ICU. If we started with for psychosis, if taking antipsychotic for psychosis, then psychotic exacerbation is possible. That's why benzo is especially increased. ECT is suggested. I have never administered ECT to a child, electroconvulsive therapy. If child is not responding and there is not any decrease in complaints, ECT is directly suggested. It says that it may increase dopamine synthesis and release in order not to allow the child die and in order to interfere. This is a method used, but I have never used it in my practice. Mild or early benzodiazepines. It's high-dose benzodiazepine until nystagmus come to 4. Dopamine agonists, Parkinson's disease, drugs, if there's hypermetabolism. This is mostly seen in Parkinson's patients, came with agitation, or REM sleep disorder, which is a first sign of Parkinson's disease. For example, we have a REM sleep disorder. There's a rigidity. If it exacerbates, especially for adults, I'm speaking for adults, we are not seeing this picture a lot in our clinic practice, but if cerebral palsy is coming to us not with more spastic, but mostly involving basal ganglia, it begins with distress. We are adding benzodiazepines, and we are starting it before going worse. Okay, this happened. Will it happen again? It's a madness, you know. It's a madness. They give again antipsychotic and see that there's a recurrence rate of 50%. They decided decreasing the potential risk factors. What will happen if there's an organic brain damage? We cannot change it. Start in the hospital, gradual titration with low starting doses, and especially clozapine with the lowest risk is suggested. But even in clozapine, we see the same. If it happens in clozapine, rigidity is less, hyperthermy is told to be less. In serotonin syndrome, I thought about malign syndrome. Serotonin syndrome is mental status change, autonomic hyperactivity, and neuromuscular abnormalities. Serotonin is being affected. Dopamine is not going down. So dopamine's effect on hypothalamus and its modulatory effect is not vanishing completely. That's why, of course, there's hyperthermy, but it's not as intensive as in neuroleptics. Here we have autonomic hyperactivity or mental status changes, but neuromuscular abnormalities is more like bluntness. It's related to serotonin increase, and what I mean with bluntness is, for example, if there's a spontaneous usage, we can directly diagnose. And here we have more irritability, apparently a more benign picture. In the same way, cognitively it's changing, delirium, catatonia, agitation, even up to lethargy, autonomic instability includes hyperthermia, tachycardia, diaphoresis, dilated pupils, and neuromuscular abnormalities include myoclonus, hyperreflexia, rigidity. I'm afraid that I will fall down. With neoclonus, and we are looking at the pupils in order to make a distinction. This change in blood levels, that we cannot say that we have diagnosed because of this change in that blood level, because story is very important. Serotonergic agent, what's the problem? There might be a toxication, and child will not tell it to us. There might be a newly started drug, there might be some additional drug treatment, or maybe substance or fungus poisoning or migraine. drugs which is increasing serotonin, even they can cause a kind of restlessness. If it's very mild, of course, we are not doing anything, but they just say that this drug was not good for me and they just stop. But in neuroleptic malign syndrome, it's more dramatic. It's more distressing pictures. And serotonin can go with restlessness, but it's not innocent. When they are used in high dose, we can see thick pictures, diagnosis, rhabdomyolysis, and other, and sometimes there are other losses. Again, my name is man. If there are 4 majors in mental situation, if there's confusion or elevated mood, but if it's agitation or nervousness, insomnia, it's called minor symptoms. If there are 3 major, 2 minor, we can think of serotonin syndrome. We shouldn't start neuroleptics. If neuroleptic is started, we cannot call it serotonin syndrome, because in malign syndrome we can have neuroleptic malign syndrome too. 5 minutes, even I cannot localize place. If there is clonus, there is serotonic toxicity. If there is hyperreflexity or other things, we can think of serotonic reflexity, risk factors, differential diagnosis, NMS. Here they didn't do a re-challenge, fortunately, in order to see whether or not there's another serotonergic syndrome. The other was neuropsychotic disease, so we don't have anything here, so we don't have any data indicating to the recurrence rate or probability. Discontinuation of the drugs, hydration, benzo, and ciprofloxacin is ciprofloxacin appetite syrup given by moms for increasing appetite. Benzodiazepines, in a similar way, it helps with catatonic features. Until nystagmus come to 4, they can give it us, but in very high dose, we don't need to continue. Seroheptadine generally begins with 12 milligram, increasing every 2 milligram, in every 6 hours, 8 milligram. There were some other things in terms of weights, 1 to 6, 6 to that age, etc. How we can distinguish in neuroleptic malign syndrome? The reflex goes down, but we have clearness in the serotonin syndrome. In neuroleptic, the pupils are normal, but they are more dilated pupils. We can distinguish from here and from the story. Why story is important? Because sometimes we don't know what the story is. Sometimes the patient just comes in an agitated situation. I think I don't have any other time. We have also EPS. That's all. Let's keep in mind farm and man. Neuroleptic syndrome and serotonin syndrome is okay. Just if you can tell us very shortly, it will help. In extrapyramidal syndromes, as I called, there are increasing and modulating ones. If there's a problem related to in the direct path, for example, motion restriction, or if there is an indirect difference, increased mobility. For example, the tardive dyskinesia, Huntington-Core, Stoneham-Core. These are like diseases, but if we keep giving drugs, the dopaminergic system goes up, sensitivity of the dopamine receptors goes up, and the function goes down, and the indirect road is mostly subthalamic. Increase in subthalamic nucleus distorts the indirect direction, and indirect direction challenges controlling unknown or undesired movements. For example, I'm not just sticking my tongue out and taking it back. If I am called keep it tight, I don't leave it. So because to leave is also a reflex. It's called milking. For example, keep it, they don't keep, they just keep tight and leave, keep tight and leave. It's just like milking a cow. These reflexes or involuntary movements should be stopped. Why I cannot stop them? Because it has to do with the indirect route. If there is a problem here, it's an extrapyramidal syndrome sign. All of them has dopaminergic dysfunction. It's a kind of modulation. It's not increasing or decrease. Tardive dyskinesia is related to dysfunction, and in the acute symptoms, it's just like the sudden pressure on the direct method, so tremors and other involuntary movements are coming out. And in treatment, instead of increasing dopamine, I am putting in operation the choline system, which has relatively increased. If dopamine went down, I am suppressing cholinergic system. I am administering anticholinergic, and in this way, we can treat it. And of course, benzodiazepine is a kind of dopamine antagonist. It's a more inhibiting system, the GABAergic system, for example. In tardive dyskinesia, I had a child like this. First, Korea was the diagnosis. And at the end of, we see perimordial extrapyramidal syndrome, and after this, we sent for DBS. It can go all the process to deep brain stimulation in order to decrease overactivation. I think it was too full.